Today we'll be talking about managing a neurocognitive disorder. I'm Reilly.
And I'm Ari. Neurocognitive disorders are disorders that can affect the memory and are often a result of aging. These disorders include, but are not limited to, delirium, amnesia, dementia, Alzheimer's, Parkinson's disease, and PTSD from traumatic brain injuries. The above list of disorders often begin with delirium and are followed by major changes in the individual, mild changes and/or subtypes in the different neurocognitive disorders. Our research specifically will focus on the dementia and Alzheimer's aspects. Both of these disorders focus specifically on aging and are known to cause different stages of memory loss.
Dementia is a larger umbrella relating to various disorders that all deal with memory loss and mental impairment. Alzheimer's being the most common and overtaking 60 to 80% of all dementia cases. Researchers believe approximately 10% of people 65 years or older and 45% of those 85 or older have Alzheimer's, with this prevalence doubling every half decade and expected to triple by 2050. With these statistics rapidly growing, individuals ranging from caregivers to nurses to general practitioners are looking into treatments to, if not cure, at least manage this disease. In the paragraphs below, we highlight the variety of medications, interventions, and therapies being practiced. One of the articles used in our research is Current and Future Treatments for Alzheimer's Disease. In this article, they discussed a helpful insight to why exactly so many drugs have failed individuals living with Alzheimer's or another form of dementia. The majority of the drugs being modified to help Alzheimer's are being created to stop it, not manage it. Scientists are going through hypothesis after hypothesis, trying to target different transmitters in neurons to tackle the symptoms and stop the disease completely. The drugs that are finding to have some effect aren't able to follow through and have the same effect in other part of the disease. Most importantly, these hypotheses are only able to be tested during clinical trials or post-mortem. This is because animals aren't known to develop Alzheimer's or any other form of dementia, so we are unable to use them as test models as we do with so many other medications and products. In terms of managing symptoms and keeping severe dementia patients controlled, another researcher led a consensus for antipsychotic drug use for dementia in care homes, sending a variety of caregivers, psychiatrists, neurologists, and geriatricians a list of statements and open-ended questions in order to end up with a common range of what the practice guidelines that include a set of detailed principles regarding the prescription of antipsychotics amongst people with dementia living in care homes. Some examples of consensuses include, but are not limited to, an electrocardiogram, which was advised before prescription only in patients with increased cardiovascular risk. Antipsychotics should not always be prescribed in cases of acute aggression, but only when patients' behavior can cause danger to themselves, other patients, or other people in their surroundings. All treatments involving medications should also be combined with non-pharmacologic interventions and prevention measures aimed at increasing caregivers' competence to deal with the individual. In addition to medical consultations, treatment plans should include physical therapy, mental stimulation, and nutrition counseling as well. Researchers Bossers and Associates showed that a 9-week intervention of aerobic and strength training was more effective than aerobic-only training in slowing cognitive decline in patients with dementia. In addition, a recent controlled trial of an intervention including diet, exercise, cognitive training, and vascular risk monitoring in older people at risk for dementia demonstrated improvement or maintenance of cognitive functioning after 2 years. After seeing the plus sides to medicinal and physical, both combined and separate, researchers make attempts without using more hands-on therapy.
One specific therapy that was looked at also involves a non-pharmacological treatment. Oftentimes, patients with neurocognitive disorders display some behavioral and psychiatric symptoms of the disorder. These can include irritability, forgetfulness, and confusion. Most of the time, these symptoms are simply treated with medication of some sort. The particular article that we looked at looks at not using medications at all and is entitled Non-Pharmacological Therapy for the Management of Neuropsychiatric Symptoms of Alzheimer's Disease, Linking Evidence to Practice. This article argues that the reason that symptoms are so often treated with medications rather than therapy is that there's a lack of education about other treatments, there's a low staff-to-resident ratio in certain facilities, and the physical environment that the patient is in can play a major role. This was a meta-analysis study and looks at 10 different studies conducted over a 5-year time period. Although not every study they used showed significant statistical data, it did show a positive trend to using non-pharmacological therapy. By educating and working with caregivers, these behavioral symptoms could be reduced greatly. We will use this article to show that there are a lot of other treatment options besides just medication. Another treatment we looked at involves something entirely different. The article was called Transcranial Direct Current Stimulation and Cognitive Training in the Rehabilitation of Alzheimer's Disease. This study looks at the use of magnetic stimulation that is applied to the brain through electrodes on the surface of the skull. This stimulation is thought to be helpful in improving memory or at least preventing some loss. This study was done by applying the stimulation and then asking the patient to participate in a computerized memory task. A placebo stimulation was also used and was followed by a similar computerized task. The computerized task was not the only way that the stimulation was tested, as there were also neuropsychological tests used. It was shown that the stimulation had little effect on the computerized task, but did have an effect on some of the neuropsychological tests and had cognitive effects several months later. Dementia and Alzheimer's are neurodegenerative conditions that we are learning more about on a daily basis. With genetic testing and other medical advances, we can plan ahead and take some of the intervention methods listed above and turn them into preventative health measures. Not enough people know about Alzheimer's and dementia and the effects that it has on the person and their surroundings. Most people know at least one person with one of the neurocognitive disorders, but oftentimes it is thought that there is not a lot that can be done for the patient.
We hope to show people that there are ways we can plan ahead or how to productively deal with the circumstances if they were to happen to us or someone we know. And although there is no cure, we are making medical advances every day to at least manage symptoms, hopefully eventually leading to a cure.